Hmm. Yes, whether use the new hardware and is not right now.
Not right.
Hello.
Hello, doctor. Go ahead. Go ahead.
Can you hear us now? No, can you hear us now?
Yes. Working.
Yes, yes. We are hearing. We are hearing.
Oh, great, great. Hi. So shall I get started with my talk then? Hello.
Sure. Go ahead. Go ahead, dear doctor.
Okay then.
Okay.
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 So I'm going to talk about our clinical experience of RTMS in children. So
వాళ్ళకి వినబడకపోతే ఇక్కడ చెప్తారు వాళ్ళు ప్లీజ్ గో హెడ్ అంటున్నారు.
Next slide. So obviously I have huge interests both personally and professionally. TMS slowly becoming an increasing part of my practice. So we do a lot of TMS every day. So obviously I have to disclose this. So just already the earlier speaker has already described in a great, very elaborately the history and other technical aspects of TMS in children. So I will not go into those details. I will briefly describe our experience, what we have been doing, and you can ask me questions in that regard. Okay. So just to summarize, we are doing TMS. TMS therapy has been going on for about 3 years, 3 decades now, and we are having increasing experience. And obviously, TMS in children is different in adults because of brain plasticity. And obviously, there are several concerns, ethical, moral, as the brain is in a developing stage. So there are 3 main areas where we are doing TMS for our patients. One is stroke. The other is autism spectrum disorder. And there are some metabolic disorders in which we have been doing. Just to give you an idea of how many, our experience, we have been doing for last 42 months now. So we have completed roughly around 24,000 sessions, and we have done around 1,500 patients. And 12% of these patients are children. So children are not a sizable portion, because we do mainly for stroke, and stroke is a disease of the adults. So only 12% of our patients who have done, for whom we have done TMS, are children. The youngest patient that we have done is a 1-month-old child. The oldest patient is 92 years. Obviously, when we talk about TMS therapy and in children, I just want to get started regarding the safety. There are so much concerns, especially from parents. But in our experience, we have conducted several sessions, and almost 3,000 sessions we have completed so far for children. And it is very safe. Some children have received as many as 100, 200 sessions of TMS therapy, and they have done well. They have absolutely no side effects. Even I reviewed the literature this morning, where there are very few side effects that have been mentioned. The notable side effect is seizures, but only 2 cases of seizures have been reported in children. So it's a very rare occurrence. It's a very rare occurrence in adults, and more so in children. 2 cases of neurogenic syncope have been reported in literature. We did not have any experience with this side effects. But just for completion's sake, I'm mentioning it to you. And this neurogenic syncope is something like a blackout that occurs in TMS in children, because sometimes these children come to TMS centers hungry and they are not hydrated properly. So it seems apparently good food intake and well hydrated condition will prevent the side effects. And there are some unique problems that are unique to children. So one of the most important thing is children do not cooperate like adults. Children are not many adults. Their children they are very uncooperative. They don't listen to us. They don't understand. They have their own doubts, worries, and they just can't still. So keeping them still, sitting them for 30 minutes is a big operation that we take. So we give them an option of watching videos on YouTube, and we have noticed that now most of the children are very addicted to watching the cartoons and other videos. And by making them watch their favorite videos on YouTube or other video sharing apps, we are able to gain their, we are able to distract them and make them sit for a good half an hour. These are some of the examples. So we don't put the coil, we don't use the head holder. We don't use the head holder. We use our technician. He holds the coil over the head because these children keep moving. So our technician also keeps moving the coil accordingly to see that the coil is placed exactly where it needs to be placed. This is another little older boy. He is watching videos and then getting TMS done. And then the coming to protocol that we use for autism, what we have noticed is there are two main problems with autism. One is hyperactivity and high attention deficit. So we believe that it is overactive right frontal lobe. Then there's speech disturbances. They don't communicate as well as they should. That is underactive left frontal lobe. So as always, we stimulate the underactive brain and then inhibit the overactive brain. We use 90% of the motor threshold to do that. And then coming to stroke, we have evolved our own protocol, which is called as ABS protocol, and it is based on the popular theories that are floating around. So what happens after stroke? Some parts of the brain become inhibited, while other parts of the brain get overactive. So there are these popular theories. One is called as interhemispheric inhibition theory. It means that the dominant area, that is the normal hemisphere, will prevent the refunctioning of the inhibited area. So, and then there is a functional reserve theory. Functional reserve theory is that even after an extensive stroke, there are some cells that have been, some cells, neurons that are still working, and by stimulating them, we will make them develop new synaptic connections, and also stimulate some of the stem cells that are still there, which are viable to regain the lost neurological function. And this is the protocol that we use for cortical and subcortical strokes. So for the normal hemisphere, we use 90% motor threshold, frequency 1800 pulses, and interval of 10. So basically, we inhibit the normal area, normal hemisphere. For the abnormal hemisphere, again, we use 90% of the motor threshold, and we put it over the motor strip. Then we stimulate it with the 10 and 900 pulses. Intertrain interval is again 10. And for all our patients, we even stimulate the left DLPFC, 120% empty, frequency 10, 900 pulses, and intertrain interval is 10. This is some of the standard protocols that we use for stroke patients. And what we have realized, which may not be published, and which hopefully we should be able to publish and share our data with all of you is, and all across the world, is that longer TMS therapy is better. So usually, most of the protocols, they limit themselves to 20 sessions, 30 sessions, but in our experience, more is better. So there are several children who have taken even up to 200 sessions, and they have improved dramatically. And the spasticity improves first, then walking improves, and then cognition also improves, sleep improves in all, dysphagia improves, and dysphagia also improves. Last thing, very hard to improve, is the hand function, but we had good function, especially when we have started TMS therapy early in the stroke. Brainstem stroke, 90% motor threshold, frequency 10, 1500 pulses, intertrain interval 10, abnormal side is 90% motor threshold, and frequency is 10, and 1500 pulses, intertrain interval is 10. And left DLPFC is same. So basically for brainstem stroke, we stimulate more motor areas, 90% motor threshold, and a frequency of 10. Unfortunately, I could not get a child's picture which was ready, so I've used this. So this is a stroke patient who has neglect. Who has neglect is looking to only one side of the field, eye field, vision. And then after 20 sessions, he is now looking straight. This patient is another with dysphagia. He's on a rail tube after a brainstem stroke. And after therapy, he is off rail tube and is able to eat well. This is another patient, young man, actually is a like 18-year-old child who had a stroke and he was able to regain his hand function because we did TMS therapy very early in. So all our patients have improved. We are analyzing our data and hopefully we should be able to publish this data and share this data with all of you. We have almost 170, 180 patients now. We have charting all our, we have collecting all the data, the pre-TMS scores and post-TMS scores. And we are right now, we are not in a position to share the data with you, but I can tell you one thing, our practice is increasing and because there is a significant improvement in autism scores and parent satisfaction. Children who have been hyperactive are more calm. They are listening to their parents, spending time well in class, and even communication is also improving. So to summarize, we have been in this practice since about for a little less than 3 years now. First 1 year, we were not sure between 2018, 2019, that is 3 years ago when we started, we were unsure of the efficacy. We were not sure about whether this works because we were very doubtful because we were one of the earliest doctors to take up this therapy in our country, India. And we were not sure about the safety because we are putting such a high voltage coil over the scalp. We were very afraid that that patient may have some side effects and mainly seizure. So very cautiously we started, but then in the first 1 year, we were very sure about that it is very safe. And results were just trickling. So we were unsure of the efficacy. But almost all our patients did well. So we were unsure whether they improved because of other things or was it only TMS therapy. The second year onwards, we were increasingly started believing that TMS therapy is a bona fide way of improving the quality and functionality of these patients, stroke and autism patients. Third year onwards, we have been very vocal in advocating TMS therapy to all of our patients, especially for stroke, autism spectrum disorders, depression patients. And now we have been doing TMS therapy in early stroke patients as early as 48 hours. Immediately that the patient becomes stable, we're subjecting them to TMS therapy. In one way, we are different from the other protocols is we have been stimulating the abnormal side very consistently and aggressively. Other protocols, in other trials, they have not done because they are afraid of seizures. Here, we are doing all this in a hospital setting. First thing is we have become confident that when used properly, TMS doesn't cause seizures. And the other thing is we have now developed our own experience that we have seen patients developing not any seizure. So we have been very aggressive in treating even early stroke patients. So to conclude, RTMS I think is a very, very useful and safe tool in treating several neurological and psychiatric disorders, even in children. We have noted in our experience in around 3,000, 3,500 sessions that we have already done. I think there were no untoward incidents, no hearing loss, no headaches, no seizures, no syncopal attacks. And we strongly believe that the time has come that this TMS therapy has to be incorporated by all neurologists, neurosurgeons, and psychiatrists. Thank you. If you have any questions, I'll be happy to answer. Hope I was audible. Do you hear me?
Well, is that over?
Yes, it is over. I have completed my talk. I'll be happy to take any questions if you have some.
Okay, I get it. So, any questions for
Was
Doctor?
I clear? Were all of you able to hear me?
Well, if there's no questions for Doctor, today's meeting is over. And thanks for Dr. Jaypal.
Excuse me, I got a question.
Yeah, go ahead. I'm listening. Please go ahead.
Dear doctor, I just wonder if the TMS applications is beneficial at the early stages of a stroke. For example, once the patient is being admitted in the stroke ward of the hospital, is it is it possible, or is it beneficial for using the RTMS for example, exciting those cells that are being damaged or hibernated or somehow deactivated? Uh, is there any evidence for this?
I don't think there exists any evidence as of now, because most of the trials that have been done in late stroke, and the main reason why they have taken up late is most of the trials have been conducted by TMS therapy is basically a outpatient procedure. It is usually done in small clinics. So we were lucky that we were able to do in a hospital setting. Now we have been aggressively doing TMS therapy very early, even like 48 hours after stroke. We have been started doing, and I honestly believe that that it works best when started early, because I think immediately after any CNS insult, especially stroke, there will be a lot of growth factors that release. And once these growth factors release, that's a good time for us to start this TMS therapy. I think once these growth factors get exhausted, I think the TMS therapy won't work as well as it would have been started early. So so we have been doing for the last 8 months now very early, and now we have really wonderful results. Almost all our patients are getting better. So obviously I am trying to collect this data and put it together in a format that would be useful to all of you.
Okay, thank you so much, dear doctor.
Yes, thank you.
Another question that I got is that which protocol are you using for getting the better results? Are you using the inhibitory protocols or excitatory protocols once using ATMS?
Yeah, I think we don't need to be shy about using the stimulation protocol in stroke. One of the reason why most of the trials they have used inhibitory protocols for the normal side. I think a combination of using inhibitory protocol over the normal side and stimulating the abnormal side gives you the best results. See, we have been not afraid of stimulating the abnormal side, because we are doing it in a hospital setting. And one thing is, we have become very confident that patient won't develop seizure, because now we have almost 30,000 sessions, 42 months of experience. We have never had any seizure. So we have become confident. And one more thing is, even if the patient ever develops seizure, since we are doing it in a hospital setting, we are in a position to take care. So we are not shying away. I think that is one of the reasons why we are getting good results, and I definitely look forward to share all this this data with all of you. I'm collecting this data of early TMS in stroke.
And dear doctor, you mentioned that you have been working to, treat the children through the TMS as well. Have you seen any evidence of treating the epileptic children via using the TMS?
Yes, actually, there is evidence. There is evidence. There is evidence, and I will not be able to quote that evidence offhand, but there is considerable evidence floating around in the world literature. And based on that evidence, we have personally done several patients. And I do remember, I can, I would love to share this detail. He is a young man who had some sort of perinatal insult, hypoxia, and he developed occipital ischemic lesion, and it was a source of epilepsy for this young man. So we used an inhibitory protocol, and we were able to considerably decrease the seizures for this young man, because he had tried several drugs and he was not, and since he had some vision, we could not go for a resection also. So we offered this inhibitory protocol over the seizure focus, over the occipital lobe. And actually this gentleman, he was very happy. Actually, we did conduct 2 years ago TMS, first TMS workshop, and Shelley and all had come. And this patient and patient's father also had come to our workshop to meet all of the delegates. And even he was so happy with the result that he sponsored our dinner also. The TMS workshop dinner was sponsored by this epilepsy child's parents, because they wanted to do something for all of us. So, when nothing helps, we should try TMS therapy, especially inhibitory protocol over the seizure focus.
And dear doctor, what about the theta burst and burst protocols? Have you ever used them? Is it
Which one? I'm sorry. I'm
theta
sorry.
burst, and burst?
I didn't understand. Maybe you could just message me. I can't understand the question.
No problem. No problem. Thank you. Thank you.
You can put in a message. I'll be happy. I'll try.
Okay, dear doctor. Thank you.